I'd like to invite Dr. Carlos Mena, Department of Cardiovascular Medicine, Yale, to speak to us about challenging femoropopliteal cases.
Right, so the case that I'm going to share with you is a standard CLI case that comes to our institution, and is actually a referral from another institution. The patient is a 63-year-old gentleman with typical risk factors, including type 2 diabetes, hypertension, a smoker with COPD, and had a transmetatarsal amputation in the right lower extremity. Early in September of 2012, he had a non-healing ulcer at the tip of the left great toe. Subsequently, he developed osteomyelitis in that location that led to a partial hallux amputation. At the time, he was evaluated by one of our vascular surgeons that did an angiogram and basically showed that there was no significant inflow disease, as I'll show you, but the only vessel below the knee was a peroneal that had some disease distally and was angioplasty. That's how it was described. This is when the patient presents with a fever and non-healing ulcer in the amputation site. You know, as we had discussed earlier during the last symposium, the multidisciplinary approach is important. In addition to look at the foot, we also evaluated the patient from the cardiac point of view. And we did a stress test that showed basically a high-grade or high-risk stress test, which basically means likelihood of multivessel disease that is probably going to need either a surgical and/or a percutaneous intervention. This is what the foot looked like at the time of evaluation. You see an extensive amount of tissue loss that you can visualize there. So the patient is taken to the angio suite, and an angiogram is performed. And I don't have all the original angiograms, but I was able to find this one, which I think is a good example of what the leg looked like. So basically, to review it, the patient has a calcified CTO in the mid to distal SFA, which reconstitutes bicollateral into a popliteal segment that is diseased as well, and has significant disease below the knee. In this case, you see that the below the knee disease, he has an occluded PT, a diffusely diseased peroneal, and some hint of the AT. So, any questions, comments? What would you guys do at this point? Anybody?
Can suggest?
Yep.
Recanalize the SFA occlusion and do a better angio to see the runoff in the below the knee arteries.
Okay, perfect. How would you recanalize the SFA percutaneously or surgically? In other words, a FemPop or?
I think in this situation we'll plan to go endovascular.
Endovascular. That was our original thought as well, partially because the patient was going to need, we subsequently did a coronary angiogram, was going to need bypass, and then we were going to use the vein as conduit for his heart. So we figured that instead of offering a patient a surgical approach for the lower extremity, we would do an endovascular approach. So that was the rationale, and this is the angiogram. After the patient underwent a percutaneous approach and was not getting any better. Oh, did I miss one slide? So here is the angiogram. So the patient gets an angioplasty and stent, but is not getting any better, and the patient is referred to us.
So this is the post-angioplasty.
Yeah, but several weeks, months, maybe in between the SFA stent that you can see here in the proximal segment. And the hope originally was just that by fixing the inflow, he will get better, but he didn't. So because of that, he was taken again to the angio suite, and this is the angiogram. So we are with an antegrade approach in the left lower extremity. We can see that the stent begins here, but it stands all the way here, and that there is a significant AV fistula. There is significant disease in the popliteal as well. So there are no clear stent fractures, but the stent is somewhat deformed, especially around the AV fistula segment. I don't know if you can appreciate that.
And how are the outflow vessels?
Say that one more time?
The outflow vessels, the tibials.
The outer flow vessels, no, they were not intervened upon originally. So in theory, looked the same as they originally looked. Although I give you that the original imaging wasn't the best. But clearly there is an inflow problem, and before we go into the below the knee, we got to deal with this. So what would you guys do at this point?
Tract?
I'm sorry, I couldn't hear you.
Do you think this stent landed in the subintimal tract, the stent that was placed? Is that there's official, or I mean, do you think it landed?
Unfortunately, I didn't have the original angiogram after the initial stent placement, but the report is that it was a subintimal passage, but they obtained a good result at the end with an inflow line to the TP.
So one thing that worries is the angioplasty, and there's an area that was not as good, so the stent was partially in a subintimal tract, and I mean the rest of it. So
yeah,
maybe that's why there's a official.
Absolutely. The point, though, it was that at least at the end of the initial procedure, there wasn't this AV fistula that we're seeing here. You know, it's not uncommon to have those AV fistulas after you open these vessels, especially when you are in subintimal space, but often a prolonged balloon inflation or the stent itself would heal it. No, I don't, but let's assume that they were fine as he was describing the operator note, and this is what we got right now. So what do we do with this? Any
Anyway,
takers?
we have to make communication between the proximal, the third, and the down third of the SFA, and covered the situation with the communication of the vein.
Okay,
So we have to find the track
Okay.
between the second and the third of the SFA, and try to find a solution with the AV fistula, which should also make.
So you would suggest further percutaneous intervention, basically, and trying to identify where the AV fistula is and cover that. How would you cover it?
I don't know. I'd like to be safe with the distal part first. Go with the catheter in the popliteal, or in order to be sure that I am in the right way between the two part of the arteries, and then I don't know. Could be a covered stent with a Viaband,
Okay.
or
So-
if it's really short with the fluency, or I don't know.
Okay, so you wanted the below the knee anatomy. So you can see that the popliteal segment is diseased, and there is a significant disease in the TP trunk, as well as the origin of the AT and the peroneal. I'll give you more injections below the knee. Here you see that the peroneal is diffusely diseased, and the AT as well. Your point is well taken as to the picture probably should have been taken from the popliteal segment in order to do a selective angiogram. But when you get these referral cases, you don't get all this stuff that you want. It's like Christmas. You get what you get, and you got to deal with it. And here is the TP trunk as well. And that's what we got. So that's the distal flow, and that's the pattern of the SFA. So what would you do? I gave you your outflow information.
I think I'd put a Viaband across that.
You put a Viaband.
I'd put a Viaband across it. I would image the outflow vessel. I'd do a tibial angioplasty, optimize the outflow vessels.
Any concerns about? Yeah, please.
And one other option is just to go through the venous side. I try to see the communication between the artery and vein and close that communication. And so the inflow will go down instead of shifting to the venous side.
Okay.
I mean, the problem is that if you put any cover stent graft here, I mean, the artery is too small and the outflow is very bad, you know. So I think whatever you're going to put, if you anything covered with small artery and very bad outflow, this will be included sooner or later, you know. I think the best way if we can improve the outflow, I mean, we have to go to the peroneal and do angioplasty, increase get better outflow. And then for this one, if we maybe we just prolong intubation, inflation of the balloon will solve the problem. Even if you still have some small AV fistula, I don't think a big problems, you know. But to go and put a stent, either covered or uncovered, in this artery with very poor outflow, I think can create a problems, you know. Unless if you go to your outflow artery, try to fix them, like a peroneal obstructive artery, try to open them. Or if you decide to put cover stent, I think then the patient has to be on warfarin at least, you know.
Okay.
It's my recommendation.
Yes.
Same way, we can try compressions because it's not high flow AVM, it's maybe low flow. We can attempt compression and we try to recognize to do the job in below the knee.
Okay.
I think
Any
very,
other
very good
comments?
points. Yeah, I think one has to look differently at acute versus a kind of a well-organized arteriovenous fistula following angioplasty. Certainly in the acute setting, we all have seen them. You know, you re-inflate your balloon, put a cuff on the outside, and majority will settle down. But from what you presented to us, this sounds like a mature.
Right. So this has been present probably
So
for at least 4 to 6 weeks.
We don't see a lot of these, but
Right.
my guess would be that this would probably not just seal with an angioplasty, prolonged angioplasty.
Right.
And sounds like a patient with quite a bit of other problems. It's interesting to find out how you managed it.
Well, so interesting. So as I said, the patient was referred to us. So the decision before the patient was sent to us was actually to do a FemPop, which was debated because of the outflow issues that you all brought up. So actually, a below-the-knee bypass was instead done. And the patient did fine in terms of pain control, and the ulcer started of healing so far. But this was the catch. The surgeon failed to deal with the AV fistula. And the patient presented emergently again, so to speak, with a cold foot. So the bypass had gone down, and the angiogram looked exactly like it looked before the surgery. The large AV fistula, an awful runoff, and now the guy had had a major bypass. So what we end up doing is exactly what you guys suggested. What we did is we went after the outflow, thinking that we were going to use a cover stent. Clearly, a surgical option wasn't a good idea. We treated the TP trunk and opened the AT. We had a flow-limiting dissection that required the use of a drug-eluting stent. We subsequently treated the AT to give the patient an inflow vessel at least to the foot. This is post-angioplasty as well. This is the final result of the intervention in the TP trunk and the AT. We were able to establish flow to the foot, as shown here. With a very good runoff. And then the question was, what are we going to do with the AV fistula? And as it was suggested, we decided to use a Vivan cover stent. I purposely left this behind because I was still worried that I was going to use a cover stent. The inflow, even though we fixed the AT, I wanted to just spot stent where the AV fistula was and take care of that and let everything else behind. So we identified the AV fistula, which was roughly around here when the vein was. We put a Vivan, and then the AV fistula resolved. Subsequently, the patient did fine. The amputation side healed, and there were no any other issues after the care of the patient. So I think that the case highlights a few things that I wanted to bring to your attention. Number one, the multidisciplinary nature of the treatment of CLI patients. Number two, the importance of recognizing the issues related to inflow and outflow when you are using cover stents. And if you are not able to address those, you're going to definitely have a problem. So I have another case, but for the sake of time, I think I'm going to skip it. And I don't know if there are any other questions, comments.
So why did you leave that like aneurysmal part behind? So.
Because number one, I don't think that there is enough data to understand the long-term meaning of this, rather. Covering it, the only thing that it was going to do when I did this procedure was just extend the length of the segment cover, which in theory could increase the risk of having further issues. So my view was short, sweet, out.
So what do you think that represented? Because it wasn't present at the initial.
Yeah, I think that if I have to guess, as it was alluded before by one of the persons in the audience, it was a total subintimal angioplasty and a stent. There are probably some degree of the deformity of the stent in there that led to that aneurysm formation. That was my best interpretation of it. I did do an intravascular and ultrasound. There wasn't any significant fractures or anything there. Could I have covered? Sure, but again, that was the rationale for not covering it.
So are you concerned that might be caused, like, in the future, some distal embolization or anything, like if it forms any clots? Or?
I doubt it. The patient was going to be on aspirin and Plavix long term, so I wasn't really that concerned about that being a problem.
It certainly warrants follow-up.
Yes.
Can I ask you a question? Now, if you had this patient again, the same situation again, what do you think the cause of the failure of the fem distal graft was? Was it the steel phenomenon?
It was definitely the steel.
So would you, in the next patient, just embolize the fistula and leave the vascular surgeon to deal with the distal disease?
That's
kind of the way they had done with it? I mean, so
yeah. I think that if I had to do it all over again, either I embolize it or cover it, and let the surgeon just deal with the bypass, with the distal bypass, if that's going to be the case. Yeah.
But I make the point that actually you can treat the arteriovenous fistula and revascularize the leg with what you did.
Right.
So you put a covered stent that improves the blood vessel to the leg and treats the fistula, and you do a tibial angioplasty to improve the outflow. It may not be a very good long-term result, but it might well just heal your wound.
Well, so the key is that, in my view, in our view, the key is what's the best long-term result for a patient like this. Clearly, if you're going to use a venous conduit below the knee, although the patency rate is not 100%, as we well know, I think that compare that with a very severely calcified vessel, which we had to put drug-eluting stents. It wasn't focal like in all the drug-eluting stent trials where they were focal with great patency rate. In this case, we put actually about 30 to 50 millimeters of drug-eluting stent. The natural history of that is the probably is going to re-stenose. How soon? Unknown, probably enough for him to heal. But I think looking at long-term patency and better outcome, I think that the surgical revascularization is not an unreasonable approach to do. I think that the problem was leaving that AV fistula alone.